Alrighty, let's go ahead and get started. So welcome everyone. First, I want to acknowledge for this particular webinar, we have partnered with Give an Hour to bring this to you. And Give an Hour is going to be providing free CEUs for social workers that attend this talk. I know that it's been a lot of work behind the scenes to get that going on the Give an Hour side and just working with them to get that to happen. So excited about that and very happy to have everybody join us today. So what I'm going to be talking about with Paul Whitmer, my friend and colleague. I'm going to introduce Paul here. He's an Army veteran and a Stella ambassador, which means that he has been treated by Stella and is here to share his story. And so Paul and I do this webinar together. I'll be giving a briefing of what our approach is to trauma care at Stella, and then Paul's going to share about his personal treatment story. So this is Healing from Post-Traumatic Stress Injury, a new model for care, because this really is about a bigger thing than just one treatment. Okay. Here are your learning objectives. I want you to be able to describe at least 2 sources of emotional trauma. There are a multitude of sources of emotional trauma, but describe at least 2. Describe at least 3 of the specific symptoms of emotional trauma that stellate ganglion block appears to most directly address, and identify at least 2 benefits when addressing trauma in a collaborative way through the fusion of medical and psychological approaches. Okay, so here's your overall roadmap for today. We're going to hit on these kinds of topics: why it matters, common barriers, talk about SGB, talk about some of the history and research, talk about the safety and efficacy of SGB, and then really propose this new model of care, which is combining biological, psychological, and mind-body practices. Then Paul's going to share his story and then where to go next. Okay, this is going to be new content for you, Paul, because I added this based on feedback from my team about really wanting me to talk about the psychological macro view and micro view. And so this will hopefully be something new. All right, so cool. All right, so the macro view is going to look familiar. And that's, oftentimes when we talk about a problem, we look at the statistics. How many people does this impact? What kind of an impact is this having? The statistics are sobering and may be familiar to those who are on the call, but 144 million people suffer from post-traumatic stress around the globe. 8 million Americans suffer each year. And some of these stats are collected before the last 2 years, which has been obviously a time of endless trauma for many people with multiple layers of trauma. So there are specific sectors of the population, including frontline workers, ER docs, physicians, nurses, and medical care providers, as well as staff who are subjected to higher rates of PTS because of the work they do. So 25% of frontline workers develop PTS, post-traumatic stress, from COVID-19. The rates for men and women are fairly comparable, men a little bit higher, and 70% are non-military. So a lot of times we think of post-traumatic stress as a veterans or military issue. It's not. It's a human issue. Lots of death and loss in the past 2 years. Just want to acknowledge that. And the implication of that, it comes with a lot of traumatic grief for people across the entire globe. Some research shows that up to about 30% of people in the post-illness phase of COVID experience symptoms of post-traumatic stress. Doesn't mean they're all diagnosed with PTSD, but they experience many of the symptoms associated with post-traumatic stress. The calls to police regarding domestic violence during the shelter-in-place effect, this was in 2020, increased and have remained heightened compared to baseline levels before the pandemic. So domestic violence rates are up. I don't think we even have those numbers. And it's very hard to get accurate data on that. But what you've had is a lot of people essentially under high levels of acute stress, some losing their jobs, stuck at home, and having a lot of rage and conflict as well as alcohol abuse rates have gone up. I read something the other day about how alcohol manufacturers, firearms manufacturers have sold a lot of product in the last 2 years, an explosion of product. Why? Because people are feeling fearful and they're looking to defend and protect themselves. And they're also, coping with the events that have unfolded in whatever ways they can. And for many people, that's been an increase in substances, including alcohol. There's a micro view too that really matters. And this is the new content, Paul. And I really want to expand on this in future webinars. So this is just a preview of really where I'm going with this series to talk about not just a treatment, the SGB treatment, but a philosophy and a model of treatment that Stella espouses. And the micro view psychologically is that there are a number of myths and misunderstandings that create human suffering that is impossible to calculate or capture in statistics. A myth, for example, that I already discussed is that PTS, post-traumatic stress, is a veterans issue. And what can come with that is veterans are the only ones who suffer from PTS, that all veterans suffer from post-traumatic stress. Not true, not true. And that also, if you haven't had an event like combat or sexual assault, military sexual assault or otherwise, you're not really a trauma survivor. This is a very common theme among trauma survivors across trauma types, and something that I'm really getting after on my new podcast, The Story of Our Trauma. I'm bringing on a wide range of guests from different walks of life, different trauma types, and really talking about what trauma is and how it impacts us. Because otherwise, people will suffer in silence. If the event that they suffered wasn't a big trauma or an event that left them feeling helplessness and horror, they may feel like they don't deserve treatment, or they're not really a trauma survivor, or don't really have symptoms of post-traumatic stress that warrant treatment. And that is just not the case for many people. Trauma is caused by things we can't see. And trauma can happen because of what doesn't happen for us, parental abuse and neglect, as much as what happens for us. Trauma can happen because of an accumulation or a layering of multiple events. And we've seen this very clearly in the past 2 years that, we have this story about trauma, which is, well, you were assaulted, or you were robbed at gunpoint, or you had a wartime injury. That was the story, the old story. We need to sort of erase that and look at trauma in the big picture, which may be that multiple events, the pandemic, living in fear, chronic hypervigilance about, a virus that you can't see, the election, whatever way it went, just the tension, the division in our country around our political leadership, who, how, what is their policy, the end of the war, how that went down, natural disaster threats, fires, hurricanes, different, natural disasters that have picked up in terms of frequency and severity in the past 10 years. Racial trauma, the killing of George Floyd and what that means symbolically, the killing of Asian American people in a mass shooting and what that means symbolically, when old people in the Asian community get attacked and randomly killed, what that means symbolically for those groups of people. So it's a layering effect that produces this sense of the world is not a safe place, and I'm not safe to navigate this world or these relationships with people. So I have to always be protective, always be defensive, and have a tunnel vision and really screen for where is the threat going to come at me, instead of be open and how do I enjoy this life I've been given? How do I enjoy this time, this connection I have with people, with my deeper purpose? Those are different questions. And a lot of people have been sent down the chute of chronic threat response, is what I'm calling it, rather than an openness and an ability to really enjoy the time they're given. There are many barriers to treatment, many barriers. And some of them are mental health stigma, feeling like we are less than or inferior or broken if we have a struggle or challenge with post-traumatic stress symptoms, reluctance to seek help after trauma exposure for a number of reasons. A lot of people, when they are sexually assaulted, as we know, don't report it or don't press charges. And asking somebody who has had an assault or some other trauma to talk about the worst day of their life with even a licensed therapist is a bridge too far for many people, and they won't do it. So that is a reality that I am going to be bold about increasingly, that I do believe and have seen how exposure-based therapies can be helpful for people. But if that's the only thing we're offering, it's not going to be something that a lot of people who suffer are going to pursue. And that's a problem, because we're missing those people for whom that is too great a challenge, too aversive an experience, and they just vote with their feet and they don't come to therapy, and so they suffer in silence. Concerns about receiving a diagnosis, getting something charted in your medical chart that maybe follows you, or becomes an identity-related factor of seeing yourself as having a condition or a diagnosis for the foreseeable future. People drop out from care, when they do trauma-informed therapies, even with good therapists who believe in the treatments they offer. People drop out from care because oftentimes it gets worse before it gets better. And there will be some percentage of patients in the current model that are going to say, I'm out. That's not something I'm interested in coming back for. Thanks very much. And so there's a lot of attrition from care with trauma patients in general. Treatment takes a while. It's not instant with the current models we have. In the best case, therapy, whether it's EMDR, prolonged exposure, CPT, it takes weeks, sometimes months to have a full effect. Same thing with medications. They work in slowly and they flush out quickly. So they also take quite a while before somebody feels relief. And a lot of people don't want to be on medications. I don't think they're bad. I think medication can be very helpful for some people. But people have barriers to taking medications. That's a reality. And then the cost of traditional treatment, a lengthy course of therapy, cost of those sessions with a really good doc, it adds up. And medications, it adds up. Even when you have insurance, there are financial costs for care. Stellate ganglion block, or otherwise known as SGB, is an innovative, promising approach, among others. Today, I'm going to focus on the SGB. In this webinar, I'll spotlight it, but as we continue to develop this content, I'll also start talking about ketamine and some of the other treatments. I just did a podcast interview that'll come out in about 3 or 4 weeks on somebody who benefited from a psychedelic treatment. And I wanted to hear about that experience and how it helped her specifically. So there are innovative treatments. I don't believe that one treatment is the right treatment for everybody. I do think SGB is a wonderful first-line treatment for a lot of people for a number of very specific reasons that I will cover. So SGB, stellate ganglion block, is a neuroscience-informed innovation based on the understanding that trauma is not mysterious. It's not invisible. You can see it if you have a brain scanner that is precise and finely tuned. And PTS causes a biological injury that is also maintained by changes in how we think and behave. And that is why the fusion of biological treatment and psychological treatment both are critical. So the analogy would be, getting a knee replacement is the biological treatment, and then the physical therapy is what you do to build up the muscle structures around your knee once you've addressed the injury. It's the same thing with SGB and therapy. You've got to build up the structures, the ways of relating to people in a non-traumatized way, new patterns, new ways of thinking about yourself, your identity, and navigating the relationships you have with people you care about. So SGB is used for trauma in the sense that trauma exposure leads to biological changes. It puts us in that state of chronic threat response. And, I had said in the learning objectives that there are a couple of, or some specific symptoms that SGB treats, and I want you to know at least a couple of them. Here are the 6 symptoms that SGB treats. chronic hypervigilance, so scanning for threats, the startle response when someone walks up behind you and you jump out of your skin, or if you hear a loud noise, it's a very aversive physical reaction you can have. Difficulties with sleep, so disrupted sleep, tossing and turning, nighttime agitation, all related to that. Difficulties concentrating, which has to be related to not getting good sleep, of course, for thinking critically. And then there's also floods of anxiety or panic, and overwhelming floods of anger or irritability that's out of proportion to the situation you're in. So SGB targets the hyperreactivity symptoms of post-traumatic stress. And some people have said, not myself, but it's a good description, that SGB can kind of reboot the system and bring your overactive fight or flight system back to a state of calm. That I have seen repeatedly with many, many patients. What is it? I mean, to me, the first time I heard this, it just sounded so weird. So I will acknowledge that openly. If you've never heard of SGB, to say, hey, there's an injection you can get in a cluster of nerves in your neck called the stellate ganglion, and it can make you calm again in your own body. That sounds pretty weird, but it actually, I've again witnessed this with so many patients in the operating room that I now really, it's just, I totally understand how it works, in the sense that there's a cluster of nerves in your neck that helps regulate your fight or flight, your level of arousal. And this procedure, stellate ganglion block, has been around since 1926. It's been used thousands upon thousands of times for almost a century. In one study alone, it was used for pain conditions with 40,000 subjects. So it's traditionally used for pain conditions like complex regional pain syndrome, shingles, and phantom limb pain. Many providers, to include myself a few years ago, have never heard of this because it comes from a different discipline that's really removed from what we typically do as mental health providers. So learning about this, at first was kind of an interesting experience, but it's been adapted to treat traumatic stress symptoms and get your body back to a state of calm. And what are they injecting? Well, this is one of the reasons I believe SGB is a great frontline treatment for many people, not only because it's like the knee surgery that you want to do first, you address the biological injury, but another reason is because it involves a commonly used anesthetic. It's not psychoactive. And for a lot of people, people in the military or law enforcement, taking any psychoactive or psychedelic agent is a problem. And so SGB is injecting typically ropivacaine or bupivacaine, which are commonly used anesthetic medications that women are given every single day, thousands of them for childbirth and other applications. So the medication itself is not psychoactive. It's not a controlled substance. There's no issues with that. So in the sort of macro view now, I want to go back out for a second. This is really the model I've been advocating for 5 years now, to really focus on developing and advocating for this model. People can get injured and traumatized in the split second. In a few seconds, their whole life can shift. The earth can shift beneath them with a trauma event. Sometimes trauma comes on slowly and piles up on us, and it's an accumulation of events. But if people can get injured within a few seconds, they can also get healed very quickly as well, if you understand the full range of treatments and innovations and support that is now out there, to include stellate ganglion block. And the other sort of big picture thing that I really have been advocating for is we need to innovate, like lives depend on it, because they do. It's not enough to say, well, we know that it's safe and we know that it's effective, but let's wait for another few years to see how the research plays out in terms of, does it help with PTS? I'm going to show you some data today that shows that it does help with PTS in a number of very large samples that have been collected by my team and other teams. And now is the time for us to be brave and be responsive to people with trauma, not just our warfighters, but also our first responders and so many populations that have been impacted by trauma. Domestic assault survivors, sexual assault survivors, refugees from several countries that are flooding into other places, totally unfamiliar to them. People in the sex trafficking, have been victimized by sex trafficking. There are so many populations that are saying, I need help. I'm not going to make it. And it's time to innovate like lives depend on it, because they do. So I've covered this, but in brief, SGB has been around since 1926. In 1947, it was first emerging in the literature for depression. Incidentally, Prozac came out around then, and kind of the medication path took flight, and that wasn't really studied after that, SGB for depression. In 2006, Dr. Eugene Lipov, my colleague, the chief medical officer for Stella, he used SGB to treat trauma. And in 2008, he published a case report about a robbery victim who received stellate ganglion block, and it really helped his symptoms. And then from there have been decades of peer-reviewed research, not just by my team, but by other research teams, including a randomized clinical trial. And here are some of those progressions. So this is a little blurb about Dr. Lipov's first published case. It was a patient who was attacked during a robbery. He was on his way for admission to a psychiatric ward. His symptoms were that bad. And he received an SGB and no longer needed to be admitted. One of the, excuse me, I should have got water. One of the research teams that has produced a number of studies on SGB to advance this work is Dr. Sean Mulvaney and Dr. Jim Lynch, as well as Dr. Brian McLean out at Tripler Army Medical Center, and Christine Ray Olmsted and her team. The commonality here is that a lot of these research teams have been embedded in the military community or done research at military hospitals. And that is one major reason why a lot of people in the healthcare field, in the civilian side, have never heard of this, because some of the places where this happens, Tripler Army Medical Center in Hawaii, where Dr. Brian McLean has treated over 1,000 cases. The Fort Bragg, it's like Area 51 for most Americans. They have no visibility on that. Walter Reed Medical Center, Landstuhl, it's just a completely separate society almost within our society that has done some really innovative things to develop this treatment. And across the board for different research teams, the range of positive outcomes was 70 to 80% for SGB. And it showed significantly positive and promising results in a randomized clinical trial that Olmsted and colleagues published in 2019. And this took place at 3 major military hospitals, Landstuhl, Fort Bragg, and Walter Reed. SGB brings relief from the hyperarousal symptoms, the ones that I've already covered. So those things like hypervigilance and floods of panic or irritability, sleep, startle response, difficulties concentrating. So that's what it really addresses in a, as Jim Lynch has said, precision medicine way. I think that's very accurate. Dr. Mulvaney and colleagues showed that SGB improves neurocognitive functioning and response time. Here's why that's critical. If you don't tell people and you don't study that it actually improves response time, there is this myth that it will block your ability to react or numb you out or dull your response. It's actually the opposite. And this research showed that, and they're actually using it for special forces operators in the combat theater and showing that it improves their performance. Dr. Brian McLean, Tripler Army Medical Center. This is a large sample. 250 soldiers received SGB. He works with active duty exclusively, and 100% were satisfied and would recommend it to a friend. And then Lynch looked at a small sample, but these were people who had used SGB with therapy. And there were about 23 people, I believe, in that study. And 95% of behavioral health providers would also recommend SGB. So here I am taking this picture. I'm not in the picture. This is my colleague, Dr. Fernandez. This is in the VA, where I used to work about 5 or 6 years ago. One of my patient X's, maybe my first or second patient, I treated him at his request, and he called me 5 years later and said, I didn't have the courage to tell you how dangerously suicidal I was back then, but it saved my life. And the SGB gives people hope, and it saved my life back then. And I said, I didn't talk about how dangerously suicidal you were explicitly because it seemed like you were communicating that to me in lots of ways based on our trust. And that is why I took some risks and arranged to have this, even though it was not standard procedure at the time at all. It's offered in 10 or 12 VAs now. You have to kind of find it, get through an extensive system of referrals in many of those VAs. It's a bit of an underground railroad, honestly. So it's not widely available in the VA, but the VA National Center for PTSD is aware of it, and there's active research going, and it's actively being used. And actually the Long Beach VA is a site for innovation around SGB. So the VA has released videos saying, this is a safe and ethical treatment for PTS. And they're starting to kind of use it more and more. But yeah, here's one of the first patients. So that was my first experience with it. We continued to do therapy after that, and he had amazing outcomes with that based on being calm in his own body. So then I was really skeptical, and this is the photographic evidence of that. A few months later, I was done with my time at the VA, my tour of duty. I had resigned. I had moved on to a new position that was very meaningful to me as senior director within the Tragedy Assistance Program for Survivors. And part of what I did on the pro bono side of my life, I always dedicate a specified volume of my time to supporting the mission without being paid. And so a major way that I do that, it's built into my life for over 6 years now, is to be a volunteer associate producer and interviewer and guest on the Veterans Voices TV show in the Bay Area. And so here I am doing an interview, and I brought on Dr. Eugene Lipov, my now colleague. I didn't know him. This is the day we met. And Dr. Brian McLean, who does these at Tripler Army Medical Center. And this is my, you've got to be kidding me face. I had seen this work for 5 patients, and I was still skeptical, and I was like drilling them with hard questions and really just needed to understand this because it sounded really weird to me that you could get a shot in the neck, even though I'd seen it with my own eyes. Now I've seen it like about 100 times, and I really do understand how it works. And this is the shift. Let me go back. That's me skeptical. That's me going, oh man, this is amazing. I was in Chicago. Dr. Lipov had just treated 10 Marines in my network that are like family to me. I was bedside, helping them through that day, and they all got their procedures together as a cohort and as a tribe. And it was incredible to just witness all of that in a concentrated way. And this is when the last of my doubts really dissolved in the face of overwhelming, deeply personal evidence that this really shifts the body and addresses the injury of post-traumatic stress. So Stella has formed. I'm a co-founder with Dr. Lipov, and we have about 50 sites across the US, and we're working hard to make this available for people across the country so they can get to this. We're tirelessly devoted to trying to find partners that can help fund it because it's not covered by insurance. We're trying to find funds that can cover it, like victims treatment funds and other funds, to help cover this, because it'll take a few years before insurance really accepts this as a treatment, even though it's done for pain. Insurance takes a while to catch up to innovation. So we have a very large network of the best docs in the country. The one exception I would make is I always comment on the practice of Dr. Mulvaney and Lynch is in Annapolis. It's not part of Stella network, but if folks live in Annapolis, I have often directed them to that practice. They're also really good. But barring that practice, I would say that it's really important to get with a qualified provider, because the right provider will do this in a qualified way, and it will be safe and effective with a qualified provider. I'm sorry, my dog is barking and it's becoming really annoying. Paul, I'm going to ask you to step in for just a second and just cover me for a second while I get my dog to shush up.
You bet. You bet. I'd be happy to. Thanks, everybody. It's good to have you here. Without getting ahead of myself, there's going to come a time when I'll talk a little bit more when Doc gets back. But I started this journey into SGB as a grad student, Master's of Social Work grad student in the fall of 19. And I was doing a paper on an individual, and the object was to find a treatment protocol different than CPT or PE. And I stumbled on this SGB back in 2019. Didn't know a thing about it. Now I'm a recipient, so I'll put Doc back on, but I'll continue later. Thank you.
Thank you, Paul. I had to call in fire support on that one. Oh my goodness. All right. Paul has an amazing dog named Paul, who looks like a larger version of my dog. So I know you get it. Let's talk about safety and efficacy, and then we'll get back to you, Paul, because I want to hear the rest of your story. So the idea of a good outcome, what is that? Well, one of the ways that that's constructed is through the National Center for PTSD, based on a measure called the PCL. It's a self-report assessment of how severe one's symptoms are. And a 10-point drop on the PCL is considered something to celebrate. We just published, meaning a couple months ago, a study of 327 Stella patients that were treated between 2016 and 2020. And our results show that in this large sample of 327 patients, we had a 28.9 point drop, which is 3 times better than what would be something to really celebrate. And that is another reason why sometimes people say, really, it can kind of sound too good to be true. So if you're tuning in, if you're thinking about getting the treatment for yourself, if you're thinking about working with us and treating people afterwards, after we've done our part of this journey, if you're thinking about referring patients for this procedure, see if you can come in and observe, or take a look at a lot of videos. We have a lot of videos from a lot of brave patients now that will talk about their treatment journey, and Paul's going to do it live here in a minute to really help dispel the kinds of reservations I had at first about really getting behind this. Now that I really have seen it and been able to directly witness through multiple stories of, frankly, people that there's no artifice in the people that I work with. A lot of the combat warriors I work with, they give it to you straight. And what they say is very helpful in that sense, because, you can really base your understanding on what they say. They don't perform for anybody. They just say the truth about what their experience is. So take a look at some of those videos. And we've treated up to around 4,000 people now across the US. And our docs are really good, and it matters because if this should be a straightforward, routine, safe procedure, but if you go to somebody who's not good and not properly vetted, it can be dangerous. It's like an F-18 jet, and if you had a qualified pilot with thousands of hours in the cockpit, and you said, take it off and land it, they'd be like, what else do you want me to do? That's, I can do that. But if you don't have a qualified person, if you ask me to do the same thing, I'd probably crash the plane. So it's like that. You really do need to find a skilled provider. And one of the things about Stella is that our leadership in the Dr. Lipov domain and a couple other colleagues that help vet and train the Stella MD providers, they know who's good. We're all a little different under the neck. Our vasculature, where things are physiologically, it's not a formula. You have to find a really seasoned and skilled physician. And just like I can tell if somebody's a really good trauma psychologist who gets it, as far as veterans and first responders, they can tell who's good in terms of making the injection. And so part of what you get with us is that takes a lot of time and resources to find those people, to say no to the people who shouldn't be part of our, brand and reputation as a high quality provider of this. And then all the training that we offer and invest in to make sure they're getting trauma-informed training. And based on this study that we just published in Pain Physician, 327 patients, looks like our results work. No matter what your source of trauma is, across multiple sources of trauma, effective results, whether it happened in childhood or more recently, SGB still works. So the new model is that, by treating the mind state barrier, by helping get people calm in their own bodies, they'll be able to concentrate. The brain will not be under high stress and have difficulties concentrating and be distracted and pulled out of the room by high anxiety, problems with memory, confusion, all of that. These are real barriers to care that I think we've really missed because we stay in the psychological track and we don't think about how is the biological interacting with the psychological. So that's part of the new model for care. And what SGB does, and other treatments like ketamine, and I think psychedelics will prove this out too, is they potentiate and accelerate the work of really good docs and treatment providers, social workers, mental health providers of all stripes. And that's because PTS causes a biological injury that's also maintained by changes in how we think and behave. So SGB opens this window of opportunity and it creates the right conditions for an optimal outcome, but people still need to do the work with good providers to get those long-term gains. That's a major determinant that I've observed repeatedly. People say, how long does it last? How hard are you willing to work? It's like saying how long am I going to be in shape? I just trained for this marathon. Well, it depends on how much you do to keep, in shape, right? If you just lie on the table and you get an injection and you don't do anything else, it doesn't make you immune to stress. And we don't believe in making SGB, something you get every month or some, chronic rhythm of your life. Some people may need another treatment, in 6 months to a year. But many patients don't, and they can go for years and feel sustained relief. Some never need to be retreated if they do the work and they don't sustain any further major traumas, because again, it doesn't make people immune to trauma. Over to you, Paul.
Hey, thanks. Good stuff, Doc. Okay, so here I was, a grad student in 2019. I'm an Army veteran, like Doc mentioned, 3 tours in Iraq and 2 in Afghanistan. I'm doing a research paper on alternatives to CPT and PE, and I stumble into SGB. Didn't know a thing about it. Didn't ever think in the world it would apply to me and have an impact on my life. I was greatly mistaken, and pleasantly so. Fast forward, 2021, March, almost a year ago, March 31st will be a year. I traveled up to Chicago, met Dr. Lipov himself, and received an SGB injection, right side, 1 injection only, without sedation, no problems. Let's talk about what happened after that. Immediate sense of calm. Okay, immediate. I'm talking driving back from Chicago, totally calm. Hadn't felt that way in, my last tour was 2011. So it'd been some time. I'd been dealing with the hypervigilance, the anxiety, the depression, the frustration, difficulty sleeping, just about everything Doc mentioned. And let's throw a little excessive alcohol intake on top of that, just to make it one big nest. So I got the SGB, came home that day, March 31st, 2021, date I'll always remember. Drove back from Chicago, and we're about 2.5 hours south. So I just remember looking out the window and looking at the farms and looking at trees and just feeling calm. Got home and laid down, went to bed that night. I was reading a book, fell asleep with the book on my chest, and woke up about 9-10 hours later with the book on my chest. Hadn't happened like that. I haven't had sleep like that in 15 years, and that's without a doubt. So post SGB, as I was starting to fit into this and starting to feel how I'm supposed to feel, it didn't require a whole lot of effort on my part. Doc, I'm going to let you check that the chat box side in case of questions. So the shot took for me a couple unique physical characteristics of the shot being effective or being in the right place. Some weakness in the face and on the right side, because I got the injection in the right side, and some reddening of the eye, little soreness of the throat. Those things were gone the next morning, so it's no long-term ill effects, but I do want to mention it. In addition to immediately getting good sleep and immediately feeling calmer, anxiety level plummeted, depression, which, I'm not a big fan of admitting being depressed, but I just felt better. I felt happier. The sun was brighter. The birds were louder. All these things were better. My relationship with my wife and my family picked up. I used to kind of hide out and get away from people that didn't go through the things that I had gone through. And then I found myself wanting to engage and wanting to interact again. Patience is a good word. I think I developed patience. I don't think I really had patience in a long time. And now suddenly it's back in my life. And I've got the chance to receive input from people that are talking to me and process that and respond accordingly. Before, it would just hit me and I would kick out a response. May be appropriate, may not be. So I developed a filter. That filter that was missing, that had gone away, that eroded away with the trauma, had been rebuilt. Alcohol use plummeted. To this day, almost a year, alcohol consumption is rare. Rare. And I think that's because with all the other things being subdued, I didn't need the alcohol anymore. So win-win. Like Doc mentioned, the SGB isn't a silver bullet. It really helped me in my relationship with behavioral health providers. Okay, I work with a special forces officer at Rush University, who's a psychologist. And prior to the SGB, I think our conversations lacked depth. I don't think they were intimate, to phrase it. And after SGB, the doors came down and we really started to interact, and I really started to get the benefit of good therapy. So the SGB made that possible. Doc, I don't know. I'm kind of, is there anything I'm missing?
No.
So, a couple other things post SGB. I've attended some warrior retreats, Wounded Warrior Project retreats. Those have been awesome. Interacting with other warriors and spreading the word and getting, other tips and tactics on how to deal with things. But I find that I'm kind of ahead of the game amongst my peers.
Yeah.
Having that SGB injection really kind of puts me in a patient calm state where I see other people and I see them banging off the walls. And man, that was me. That was me for a long time. That was me. And it's very refreshing to not be that person anymore and to be back to my, my pre-trauma self, if you were. So
Your quality of life has just
oh,
shifted immensely. I want to comment on one thing and then ask you a question. The comment I have is that, you are not somebody who takes a passive approach to growth. And that's what we really want to advocate for in terms of this new model. You're a seeker, you're working with a good doc, you've attended Operation Mend, UCLA's IOP, you've attended some Wounded Warrior Project retreats and benefited from those, from being in a calm body as well, which has laid the groundwork for that. When I say, here's the question, when I say we need to innovate like lives depend on it, because they do, what is your response to that? And how does that resonate with you personally?
I think that I look at all the time that I just almost feel like I wasted time. I almost feel like I wasted years of my life that had I gotten SGB prior to when I received it in 2021, I look at the things that would have been possible then. Now, I don't look back and go, oh, life sucks. I look at, man, let's look what we've got ahead of us. And like I said, the sun is brighter and the birds are louder, and let's move forward. I think that, one of the things you touched on was the stigma that can follow people when they seek behavioral health solutions. And in the military, that stigma is massive. Okay. Most chains of command, and I was an officer, most officers will tell you that they, they'll support it, but in the back of their mind, they may not, especially when it's for themselves. So you really have to step out there and make that leap. I mean, I had a real unique case, well, maybe not unique in military parlance, but I didn't really have a singular intrusive event. And it made it hard for a regimen of CPT or PE to be effective, because I didn't have that one event where everything went wrong. I had spent 5 tours overseas. I've been rocketed and mortared and bombed and IED'd and shot at and seen, killed and wounded friends and foes. And none of those, I didn't have nightmares about that. I didn't wake up and say, oh, there was this one time that, so I didn't really have a starting point for CPT or PE. SGB got in there and just kind of knocked all that down and made it so that my therapist and I, my psychologist and I can discuss things, and really have benefited from that.
Awesome.
Can
Awesome.
I ask you a question?
It does. It does. You always deliver just so eloquently your truth and your experience. And as a combat warrior, you're not somebody that has artifice or, there's just, this is a volunteer ambassadorship to bring other people that are suffering in from the woods. And we're grateful for your role in this and for your co-hosting of this webinar with me every month to get the word out.
And if I can add something, Doc.
Yeah.
You mentioned the percentage of military trauma participants that are people that are participating in the SGB, in the Stella program. I have worked with about 15 candidates for SGB now, and I think 3 of them were military. The other 12 were not military. So to assume that PTSD or trauma like that is a military thing only, I think is one of the biggest myths that could possibly be perpetrated. The
Absolutely.
vast majority of SGB patients that would benefit from SGB are probably civilian.
Absolutely. It's 60%, 30% civilians, 60%, about, somewhere in the range of 30% a little higher, for each to make 100, but that we treat at Stella. And so where do you go from here? One of my philosophies that is part of how we see trauma at Stella is that there is no world that divides patients and providers into two groups. A patient is someone who suffers. We all suffer, and we're all patients at times. And so I don't make those divisions. And I wanted to host this webinar for everyone to come, for providers, for partners, for organizations, for prospective patients who are not providers as well, because I think everybody that suffers from trauma symptoms can benefit. I will tell you, I had SGB myself, not for trauma, but for sleep, and it really helped me. So I think it has some applications that are really important for a lot of people. So having said that, there are a number of places you can go, and you might want to go to more than one of these places. If you want to get SGB for yourself, maybe you've heard lots of trauma stories from your patients. Maybe you've had your personal trauma, and that's why you went into psychology or mental health work. You can heal from trauma symptoms by scheduling a consultation with us. We don't charge for that consultation. Or take a look at your symptoms. We use the PCL as an initial assessment, and then we do a more comprehensive assessment with your medical history and background. That's on stellacenter.com. If you know organizations that might want to partner with us, you're in leadership or part of those organizations, or you can help access funds for people who have been exposed to certain kinds of traumas like domestic violence or sexual assault or other traumas, first responders, partner with us. Val Growth is our head of partnerships, and her email is there. If you want to be a provider who treats patients, does the therapy that's necessary for long-term gains, partner with us. We've highly invested in a training series that I wrote and narrated. Mostly Dr. Lipov is part of that, but it's mostly by me because it's for psychologists and mental health providers. It's free. You can get 2 hours of training, and then you can be Stella certified, which means you have a basic working knowledge of our part of the journey. And we want that, of course, to provide collaborative care. So you can join our network, and we'll send you patients. If we've got patients in your area, we're always going to choose the person who took time to learn about our part of the journey, so that when patients come to them afterwards, they're knowledgeable and can talk through and prepare their patients well. So that training, includes very specific questions like, does SGB change personality? How do you talk to your patients about that? Because it's a big shift very quickly. How do you prepare people 24 hours before SGB? These are very specific and concrete things covered in that training. And so Penny Hoagland is the contact for that, penny@stellacenter.com. The chat comment that you mentioned earlier, Paul, was actually Penny writing about expected effects, which are different from side effects. When this is performed by a qualified medical provider who does it with skill, there shouldn't be any long-term side effects. It would be like saying, are there long-term side effects from getting an epidural in childbirth? No, typically not. What there are with this one, which was what Penny was writing about, is expected effects. So Horner's syndrome is an expected effect. That is a slight droopiness in one eye for a few hours. After the procedure, up to 24 hours, it resolves within 24 hours. Sometimes a hoarse voice or a feeling of a lump in the throat, a dilated pupil, sometimes some redness in the eyes, or a constricted pupil. I think I got that wrong. Meiosis and ptosis, whatever that means medically. Those are the Horner's syndrome effects, and that's good. We actually look for that to make sure that we hit the right injection site. So I think that summarizes everything, and I will refer you over. Is there anybody from Give an Hour that wants to talk about, let's see, CEUs? There was somebody on here. Jessica. Okay, Jessica, I'm going to see if I can pull you in case you want to give any instruction here. Stop share.
And Doc, there's some questions popping up on the side. I'd be happy to read them to you, and you can respond to them if you like.
Sure. Okay, go ahead. And then Jesse, I just pulled you in. like with an allowed to talk thing. So, oh, it should be Brittany. All right, let's pull Brittany in. Yes, absolutely. Where is Brittany? There you are. Okay, Brittany, you should be allowed to talk now too. Brittany, before I answer those questions, actually, why don't you pop in and give any instructions about the CEU part of this, and then I'll stay on for a few minutes.
Sure, sure. Thank you so much for such a great webinar training and overview. As it relates to CEs, we will be reviewing the attendee list because, as you all are aware, there are certain guidelines for length of time and participation. And then we will be reaching out to attendees directly with the CE quiz. There is an assessment that must be taken following the training. And then at that point, we'll be able to compile all the information needed to get individuals their CEs. So please do look out for an email from us over at Given Hour to get that process started.
Awesome. Thank you, Brittany. I know how much work you put in on that with me, and I really appreciate you. All right, Paul, why don't you lob those questions at me?
Sure. I've got Midge who is asking, are there contraindications with other medication and or certain medical conditions?
The answer is yes. And I'm not a medical provider, so I'm going to tell you what I've seen people be screened out for or carefully evaluated around. Sometimes patients who are on blood thinners need to have some steps they take to make sure that, that would be true for any injection or invasive procedure. You'd want to look out for that. I have seen sometimes this be less effective for people who have a history of Lyme's disease. I have seen sometimes people with metal in their neck need to send in a scan to make sure that the injection is going to work. If there's some obstacles, some physical obstacles there. Those are some of the main ones. Otherwise, the medications for depression, the SSRIs, they're not a rule out. We actually don't encourage people to make changes in their medications. We encourage you to keep stability of your current, whatever's working. And afterwards, if you want to talk to your provider, your medication provider, about getting off of some of those medications, just tapering off, if that makes sense to you and your provider, you can try that afterwards in consultation with them. But it's not a contraindication for any of those regularly prescribed psych medications that people get.
And you kind of dovetailed into Brittany's follow-on question, which was, how does SGB affect the need for pharmacotherapy?
It depends. I mean, I really believe that some of my patients need a little bit of medication, or certain kinds of medication like mood stabilizers are part of their overall wellness plan. So I'm not somebody that says providers that give medications don't have a role, not at all. I collaborate with psychiatrists and believe that they can play a critical role for some patients. We've found that other patients are able to get off of some of the medications they were taking for post-traumatic stress when they experience relief from this procedure. And so our guidance is just do that in consultation with your provider. Do it in a smart way that tapers off, one at a time, and sees how that is going for you, so you can make wise decisions on that.
Another question through Brittany, how does SGB affect the sleep health outcomes of individuals that suffer from night tremors?
The sleep health outcomes, is that what it
Correct.
says? Okay. Well, it's, there's no kind of consensus on that. Some people have said that the SGB makes their nightmares, their intrusive images just sort of fade, that they are able to sleep with a book on their chest for 9 hours and wake up with a line of drool. I didn't say you had drool, Paul, but, just it could happen, right? You could get really good sleep. Actually, one of the things I could offer in response to how does this impact your sleep is that when I got this, it was for sleep, and my Fitbit data showed me that. So I get a little readout of my quality of sleep, and it was like poor. I would get up in the middle of the night, not always for bad reasons. I would get really, exciting ideas sometimes about the work I do, and would get up at 3 or 4 in the morning regularly. And then after SGB, I was getting regularly 7 or more hours of sleep a night. which was huge for me. And there's actually a Hollywood Times interview. If you go to YouTube and you go Hollywood Times, Shauna Springer, Mark Ang, M-A-R-C-A-N-G, he's the interviewer. I happened to do a Hollywood Times interview that was videotaped and posted the day after I got SGB. So you can see me day after I got SGB, there's not even a bruise on my neck, and you can see how rested and alert I was in that. So I can provide that as kind of a time capsule to say that, you know, I can't say it helps everyone sleep. Like I would never say SGB is the right treatment for everyone, but it has helped a number of my patients with those symptoms and just to get restful sleep.
One, Evelyn asks, cost. What's cost, Doc?
Cost. So it's not covered by insurance. In the field of cost, costs generally range anywhere from about $1,000 to $4,000. Stella invests a ton of money into finding the best docs, training the docs, providing follow-up care, doing thoughtful consultations, and other things that we do to really get this innovation elevated and lifted up. And our cost is $2,000 approximately for a single procedure, and then an additional $1,000 if a repeat procedure is needed. Based on our internal data, we found that most people don't need a repeat procedure. We get 83% success on the first double injection, and we don't treat people if they don't need it. So it's $2,000 for most people. For those who elect to have a second side because the effect is not what they had hoped, not the intensity of the positive shift we're looking for, that's another $1,000. It is safe to do that the day after. We never do it on the same day. And we never provide procedures unless they're medically indicated.
Perfect. And one more, and this is for me. We know that the VA is taking an interest in this because we've had such positive results. Can you tell me the status of any legislation that might involve SGB in our veteran community?
I sure can. And before I get to that, my colleague Penny just popped a little thing in the chat that I want to make sure everybody sees. So I don't want to like beat around the bush in terms of cost. So that's the cost. However, as I said, we have many options for people who can't afford this. And we're tirelessly at work trying to make that possible. So accessing funds, finding ways to make this covered. One of those ways is that it's often covered by health savings accounts. If you have one through your employer, you can apply it to that. It is also, we have a partnership with Care Credit, which is a no interest loan essentially, where you can pay it off in small chunks, because a lot of people, they just say, oh, I'll just pay that instead of my therapy, costs for a little while and get that under my belt. Now, we do encourage people to do therapy. So if they're already in therapy, we're not saying take that cost and reapply it somewhere else. But if you don't have a therapist and you would benefit from therapy, there are lower cost options with teletherapy now, or options that give free therapy for veterans and first responders, like the amazing network at Give an Hour has 4,000 providers that volunteer their time because they are mission driven and they want to support veterans and first responders. So, that's a therapy source that is a go-to for us. And so Care Credit will allow you to make that affordable and really fit it into your budget. And then we're always looking for partners. We have partnerships with Green Beret Foundation, other Mission 22, Operation Freedom Paws, the Acadiana Veterans Alliance, and other partners are often coming on board to help fund this for those who cannot afford it for themselves. Okay, Paul, your question. There is something called the Treat Ptsd Act Hr 1656, if anyone wants to look it up. It proposes that SGB be furnished to veterans and service members within the DoD, and that it be identified as a treatment of choice for those who want it, as an option for those who suffer from trauma symptoms. And I think they have to have a diagnosis of PTSD, was how it was written, but that it is to be furnished to those two groups. So it would be, if passed, would make this available across the VA. That's part of an advocacy effort that I have directly contributed to, directly worked with my congressman to have him be the first Democratic co-sponsor of this. We have over 20 co-sponsors of this across both parties, and the work continues to really push that forward. Laws take a long time, and so I'm going to drop in and talk with the people who wrote the bill. That's Congressman Scott Perry and his district director, Jay Ostrich. I'll check in with them and see if there's any status updates. But basically, the long and short of it is they came to me and said, we know what you're about. We'd like your help, getting support for this. This is not political. And I said, great, because I'm not political, but I will do what is best for the tribe that I support, the veterans and first responders that are so precious to me. So I've been at work on that for at least a couple of years with them, to see if we can do the right thing for veterans and first responders, because often what's adopted for veterans often becomes a standard of care for everybody who suffers. So often the care of veterans kind of leads the way. That's been somewhat historical. Any other questions, Paul, before we close out?
Midge, did you get cut off on yours? I see the first part of it. While she's typing that up, I just say it just shows the amount of involvement when the VA and the politicians get together and they start drafting legislation to push this forward. I mean, this is working. Okay, this is working, and it's really a neat time to see things move forward like this, and to see people undergo this change that I've went through, and it's just a neat time. Midge, I didn't get all your question. I got, as a mental health therapist, it should.
All right, Midge, hit us up later, because I want to be respectful of people's time. And thank you for everybody who attended. Follow up with Brittany with the CEUs if that's something that you would like to have. And thank you so much for your time. And thank you, Paul. Thank you for being a great co-host. And I look forward to doing this again with you next month.
I look forward to it too, Doc. My pleasure, always.
Have a great day, all.